Good morning, everyone. And when I say everyone, I literally think I mean everyone. We have now almost reached 70,000 therapists who have registered for this conference. About 20,000 of you are arriving to various sessions live with us, and we so appreciate you taking your valuable CE time and time away from your work, time away from your clients, time away from your families to engage in what we believe, even though it's free and we were able to offer it for free to you, we believe this is an invaluable training because we've invited many of the rock stars, the all-stars, who are literally changing the landscape of how we understand suicidal thoughts and behaviors manifest in us, both our clients and we've learned that therapists as well are not immune to suicidal ideation and behaviors. We know you have a lot of questions for those of you who are joining this giant conference, and we want you to know that we are here to help you, to guide you as best we can. There is a frequently asked questions page in your portal. We encourage you to check that out if you've got any specific questions. It should answer most of them. Your CEs will be here. Don't worry, don't panic. After the conference, you'll just click that CE tab in your portal. There'll be a big button there, and you can get your certificate anytime in the next several weeks. Any presentation that has handouts, that handout button will be right next to where you launch the presentation as well. We're going to leave time for Q&A at the end of every session today. So there'll be about 45 minutes of content and 15 minutes of Q&A, and we'll get to as many questions as we can. Again, my name is Zach Taylor. I'm the Director of Continuing Education at Psychotherapy Networker and one of the business managers at PESI, and I'll be one of your hosts today along with Sarah Mount as well. So let's get to it. Our next speaker this morning is her work is saving lives around the globe. The president of the American Psychiatric Association has noted that the Columbia Protocol is like an introduction of antibiotics to the work of suicide prevention. The US Department of Defense has commented on her work and said it's nothing short of a miracle. Her work's been noted in a keynote speech at the White House. She's given and led presentations in front of the United States Senate. She spoke there after the Parkland school tragedy. Her advocacy has changed local, national, and international policies. The Columbia Protocol is now being used across all 50 states in the United States and internationally. In 2018, she was awarded the Secretary of Defense's Medal for Exceptional Public Service. Quite a resume. So I want to welcome to the Clinicians Suicide Prevention Summit stage, Dr. Kelly Posner-Gerstenhaber.
So excited to be here at this monumental, amazing conference. So I just wanted to start by saying that talking to this audience is particularly meaningful because you guys play a critical role in actually saving and helping the people that need to be helped, because you see the difficult and complex cases and rely on your expertise and judgment to ensure that people at risk get the care they need. So I applaud you all for your leadership and care in the systems that you're in. So this was the night that Anthony Bourdain died, the last few minutes of prime time.
All right, so as Ax was telling us, Anthony Bourdain, Kate Spade, surprising losses, but they did not die in a surprising way. Suicide is a dirty secret in our society. It is a plague that has taken more lives every year for decades. We don't talk about it because, as Ax said, there is a stigma and a shame attached. Even the phone number on the screen. All right, we put it up there. It's good. It's good to get the information out there. It's good to give people a chance But there's an assumption, and it's that people in that kind of pain will have the will to ask for help, but too often they do not. The rest of us feel powerless to do anything, especially when the person in need never says anything. But maybe that's because we're not asking them the right questions. But you can. And in doing so, you might just help stop a suicide. Please do this for me and for yourself. Search online for Columbia Protocol for Suicide Prevention. Columbia Protocol for Suicide Prevention. I also tweeted out the link. Go to my page at Chris Plummer, you'll see it. What is it? 6 very simple questions that you can ask anyone that you're worrying about. One of them is whatever they ever wished they could go to sleep and not wake up. Have they started collecting pills? Have they gotten a gun or given away valuables? Basic ways to help pick up crucial warning signs. All right, you're going to be skeptical, I understand. The Marine Corps rolled out this protocol for everyone to use, from legal assistants to members of clergy. What happened? Suicides among active duty Marines went down 22% in 2014. That's a big number. But here's the catch. Maybe it's not the magic of the questions. The catch is that the protocol works because people care enough to engage. That's another thing that is revealed by suicide, another dirty secret. We need to care. Caring counts. It can literally be medicine for someone in mental or emotional suffering. So reach out. Don't wonder what's going on with someone. Ask them. We are all
in this together. So let me start by saying that this is not a problem of veterans. It's not a problem of the elderly. It's not a problem of youth. It is our shared problem of humanity. But the very good news is that it's our one preventable cause of death. Yet it has been this tragic paradox that takes more firemen than fire, more police than crime, more soldiers than combat, more lives than car accidents. Did you know it accounts for more deaths than war, homicide, and natural disasters combined? It's the number one cause of death in adolescent girls across the globe, second leading cause of death in 10 to 24-year-olds in our country. And unbelievably, suicide among 8 to 14-year-olds was up 150%. And get this, the CDC has told us that 5-year-old suicide has gone up, but also only in African-American preschoolers, which I will get to. But here's the great news. I said this is our one preventable cause of death. The suicide rate has continued to climb little by little for the past 20 years. We have now, for the first time, seen our first decrease, 2% in 2019, 6% in 2020. What does that mean? It means that whatever we're doing with messaging, identification, and treatment is working, but we still have to do more. And what I want to tell you that's quite important that relates to what I just said about the 5-year-old preschoolers is where it's decreased is among white Americans. Where we still have a tremendous issue is among minorities and our most vulnerable. You know, we've had this intersection of these two humanitarian crises. You know, we had, there was an African-American young man found hung in a park in New York. Many other states had other things. First, they weren't sure if it was a lynching. The Department of Human Rights came and said, you know, we need to help these communities. As I said, preschool only in African Americans, but we can actually do something about it. This was from Tennessee, using the Columbia Protocol to address the increasing suicide rate. But we must continue to work much harder with our minority populations. So that's suicide. What about the precursor? Did you know that the CDC tells us in your average high schoolers, 12% of girls, almost 10% of boys say they've tried to take their own life in the past year. And we knew these were gross underestimates before COVID, before we had better, more comprehensive monitoring. These aren't in disadvantaged populations. And then COVID hit and the CDC told us, you know, not surprisingly, suicide ideation went up. And, you know, at the beginning of COVID, it's so interesting. Parents wouldn't want to take their kids to the ER with high fevers. that could be life-threatening because they were worried about, the getting COVID. But the thing they couldn't not do was take their kids for psych visits, because that's how palpable and stressful it's been and continues to be, by the way. So lots of studies that have shown, this is pediatrics using the Columbia, right? Of course, ideation and behavior has gone up, since COVID. So I wanted to say, I've talked about the good news, but CDC has also told us that, do you know that we're the only developed nation in the world where the life expectancy is going in the wrong direction? All right. We're the only one where it's not going up, and we don't have a cure for cancer and we don't have a cure for heart disease, but we do know what to do about this. And it also touches everyone. 135 people are affected by every death. And these effects linger across generations because of the silence that often follows. I want to tell you that for every depressing statistic, I'm going to give you a hopeful counterpart. And quite importantly, part of, as was mentioned, the Columbia's policy across all 50 states, but it's also become a vital part of health and wellness for employees and their families. So at my hospital at Columbia, I give the first 5 minutes of every safety update before washing hands. Did you know that if you take a large corporation of 100,000 employees, every 6 days, an employee or a family member, an employee will die by suicide? Every single day, there will be 3 suicide attempts. So we also know that depression is the #1 cause of work-related absences. So by the way, if you work at Amazon or Homeland Security, they have their own app. If you're Secret Service or TSA, you have a Columbia app that connects to the EAP. So it's a vital part of taking care of each other and our employee assistance and our employee help. But you see how it says health and wellness for employees and their families? I went to give a talk at Sloan Kettering, because it is like blood pressure at most hospitals. And the head of nursing came up and said, I used it to save my son's life. And we hear that 1,000 times over. So this empowering tool can really do a lot for your families and your communities. And so we very much have had, even prior to COVID, a critical focus and need to care for the caregivers. You hear this all the time. Did you know it's the #1 cause of death for medical residents? So supervisors and other people are actually using the Columbia at, every whatever, so you can screen like blood pressure, the head of mental health at University of Pennsylvania, et cetera. We hear the stories all the time. And one study out of China, COVID, right? Not surprisingly, over 70% had psychological distress. And so, I did this piece during COVID, and the American Medical Association called me the next day and said, yes, the Columbia, but how do we get it in every doctor's hands? So you see that? Ask your coworkers, care for your coworkers. You guys are uniquely equipped to actually identify risk and help your peers. And every hospital you have can have a little card like that. And when I say all 50 states, every fireman in Texas or in Houston has this card, not only in their work. Ask your fellow firefighter. We have to care for our peers. Remember, we said more firemen than fire. And in medical students and doctors, it's a huge issue, like everywhere else. Very often, #1 cause of death in construction workers. The airlines brought me out to give it to the pilots and the flight attendants. And they said, one major airline had 8 suicides in 15 months. These are not the pilots flying your planes. These are the pilots out on disability. Suicide does not discriminate, and it touches everyone. So what we also know is that we have to care for each other, right? And clinicians often feel, and doctors and healthcare workers, that they have to be invincible. And they're often hesitant to ask for help for fear of jeopardizing their career, for fear of the stigma. And what we know is that promoting help seeking, is one of the most important things we can do. And I'm going to talk about that more. I want to shift to this national crisis that we've been living with about gun deaths. Did you also know that nearly 2/3 of gun deaths are suicides? And I always say that that guy who goes up to that gun counter to buy that gun does not want to die and does not know there's help. And that gun shop worker does not want to sell that gun to somebody who's going to hurt himself or somebody else. And so we've been working with the gun community, and VA started this, putting a Columbia around the gun lock. And how does it relate to gun violence? So, we know that 90% of shooters have suicidal issues. So I said this back at Columbine: screen, screen, screen. Let's find out who needs help before it's too late. When we had the 2 shootings in the same weekend before COVID, the town hall said this can be the highest form of see something, say something. It doesn't mean that guy behind that gun counter is going to ask everybody like you do in primary care. But if something feels off and that guy won't answer the question about why he wants the gun, he will have a tool to help him maybe save a life. So why did the head of APA call it the next antibiotic? Well, we've made 50% reductions in lots of other diseases, but suicide had, prior to now, remained unchanged because of stigma and an easy to use method by which to detect it and take action to prevent it. So did you also know that depression is the #1 cause of global disability, costs humanity more than anything, touches more people than anything? And during COVID, look at the numbers, of course, right? These things go up. This is studies from China to Iran. And we know that mental illness does not discriminate: rich, poor, black, white, celebrity, or teacher. I said that this is preventable. We know we can prevent this. We very much believe that, and the data supports that. But why have we been struggling so much? Did you know that the NIH spent more money on the West Nile virus, which kills 137 people per year, than suicide prevention? We were at the White House and we were talking about the opioid crisis and $3 billion, which is money very well spent. But suicide takes as many lives and gets less than a fraction, right? We have to shift the tide in this. And what is the high cost of not screening? And by the way, when I say cost, when you're talking about saving lives, it's clearly not about money. But when we're spending the money in all the wrong places, we can't do what we need to do to save lives. $300 billion a year in life disabled or lost. Okay. And listen to this. My colleague, Dr. Gibbons, did this important work. And this was a general medical ED in Colorado. Prior to this, 400% increase in hospitalizations, 300% increase in ED visits. Guess what happens when you start to do something about it? So Centerstone is the largest provider of outpatient community healthcare in the United States. They reduced suicide 65% in the first 20 months in just one state when they started the Columbia. They also reduced ED recidivism from 40% to 7%. Why? Why is the Columbia chosen as the global method, or pretty much the global method? Because it's the first time we have evidence-based thresholds for who to worry about and who to get care to. And that redirects resources tremendously. We also, this is another system across 2 states since doing it, 50% reduction in suicide, okay? And an 86% reduction in calls to the behavioral health service line. And that's not really only about reducing workload and saving money. It's about actually getting care to the people who need it. So I talked about Centerstone. They brought this to life by telling a story about a man who they called a few times, and he said he was fine. He said, the last time you called me and asked me those questions, I was on the bridge. The power of asking beyond the doctor's office, which is a theme I'm going to talk about a lot today. So what is one of the most important things I can tell you? You may know that nearly 50% of people who die by suicide have seen their primary care doctor the month before they die. We need to be asking these questions the way we monitor for blood pressure. Many adolescents who show up to the emergency department who've tried to take their own lives are not there for psychiatric reasons. So if we're not asking everybody and making it routine, we will not find the people suffering in silence. But guess what? We have to have that concept, well beyond the doctor's office because many people never get to the doctor. I'm going to be talking a lot about having a public health approach. So remember I said number one cause of death in construction workers. So we've been we've been working with the unions. They said, well, the safety check in the morning can be more than the hard hat. It can be the Columbia. I just gave the keynote to all the employees, all the people for the United Steelworkers, to their unions. Major League Baseball brought us out to give it to the teams. The person in the locker room for your kids' high school team. We must have that normalized blood pressure concept everywhere we are. And then when there are times of increased risk, like if you're transitioning from active duty to veteran status, if you're a baseball player that's relocated or injured, whatever the increased risk is, we can get even more hypervigilant. So I know you guys heard from my very close friend and colleague and hero, Kevin Hines, yesterday. And he tells a story, right? He woke up that morning and said if just one person asked him if he was okay, he wouldn't do it. Goes to the side of the bridge, gets off, shoos them off the bus. And this woman walks towards him and he becomes hopeful. And she says, can you take my picture? And he says, screw this, nobody cares. And he jumped and he realized, right, that all of the problems in his life were fixable, except the fact that he just jumped. And he says, most people considering suicide want someone to save them. What we need is a culture where no one is afraid to ask. And that's why these questions are so essential. And we have to have this idea everywhere where there's access to means. So the transit workers, I hope soon enough when you go to CVS, you'll get these questions. You'll see them on the wall. We have to be able to try to save somebody's life. And by the way, when somebody is feeling like that, they want to be asked and they need to be asked. So I spoke about 90% of shooters. So when the Navy Yard shooting happened, President Obama's deputy secretary said, what is it going to take to make this ubiquitous? And so we went on this show a few years ago, and he said that this can keep our 64 million children safe. And the Orlando hostage negotiators saw it and took us down, flew us down. And I said, they shouldn't have had to get lucky for that. By seeing that TV show, we need more policy. So this is the good news. That's when we had the Senate hearing. And that man sitting next to me, his name is Ryan Petty, another hero of mine. And you know what? He lost his daughter at Parkland. She was one of the 17 massacred that day. And he and Stand With Parkland, they talk more about the Columbia and early identification than they do about guns, because maybe we can stop it or have a better chance of stopping it before it's too late. And then when they had the suicides, because when you have mass traumas, there's increased risk for contagion, right? We went all over and he said, social media, grocery store, we're all accountable. So I have to tell you a quick story that I think is really important. So he got a call from another young man that was at Parkland, and he went off to college in Utah. And a year later, he called Ryan and he said, I've been frozen. I can't move. I can't do anything. Ryan did the Columbia. He was at high risk, and they got on the crisis line together. He called the crisis line with him. And that's really important, right? You should put these two things together, but don't just give a number. Hold their hand, walk them through it. It's a very helpful thing. And you know what? He called an Uber from Florida to his dorm and got him to the hospital. What a beautiful story about how things can save lives. So I'm going to shift for a moment. Suicide is a choice, a sign of psychological weakness, akin to murder, akin to cancer, or all of the above. I know there's 70,000 people are going to be listening to this. Invariably, I get a choice or all of the above. Doctors to anybody, no, suicide is not a choice. And its biggest cause is a treatable medical illness called depression. But we don't think of depression like we think of cancer. You would never hear the word choice when it comes to cancer. And what does that stigma and misunderstanding do? It actually can be lethal. The show 13 Reasons. What does that say? It says the opposite. It says this is a rational choice, not a brain-based illness. So guess what? Suicide spiked the month after the premiere. I'm just going to take a minute. I was always also the person who led the team that was commissioned by the FDA when all the controversies with medications started. So they require the Columbia as well. Antidepressant medications can cause someone to be suicidal. Actually, no, there's never been a medicine that has actually been shown to cause somebody to be suicidal, which is why FDA requires it. So you know what happened? Suicides went up when people were afraid because of liability to prescribe medicine. But now science has begun to conquer ignorance. So Chantix actually removed a black box when Pfizer presented their Columbia data. And now a lot of lives, I think, will be saved. And we're working on the same thing with FDA has told us that that's what all the data looks like. What do we know? Antidepressants save lives. Not treating depression is what kills people. Autopsy studies are invariably associated with no treatment or lack of compliance. Those are SSRIs, Prozac, Paxil. The suicide rate has dropped dramatically across the world, across ages, reversing a trend prior to their introduction. Okay, but and you know what? We also know opioids. A whole big portion of them are suicides, but even when they're not, there are people desperately trying to self-medicate in lieu of proper treatment. So if you go on the National Opioid site, you'll get to the Columbia eventually, but we have to get much, much closer to save the lives we need to save. So we know that these simple medicines save lives. What the fact is, I got to give the speech to the leaders of the European Union on how to fight depression and suicide. And I said to them, 90% of people who die by suicide have an untreated mental illness, most often of which is depression. Okay. So if you can put up barriers and bridges and do lots of other important things, but the most important thing you need to do is identify and treat. And sadly, we know that most people who need treatment do not get it. 50 to 75% of those in need receive no treatment or inadequate treatment. So years ago, when antidepressants were the #1 prescription in the country, my message to the media was that's encouraging. We worry much more about undertreatment than overtreatment. Why? Why do people not get the life-saving care they need? Stigma and misunderstanding. This isn't a real illness. I'm weak if I ask for help. This is a firefighter. It's the stigma attached to admitting you have any kind of problems that gets in the way of beating depression. Baseball to border protection. That's what the baseball players say. They can't tell their psychologist because they think there's a stigma, even with the people who are supposed to be taking care of them, right? And men, this barrier is even higher and even more impenetrable. So, men die by suicide more than women. And we used to think it's because of the methods that they chose. But my colleague, Dr. Gibbons, did this very important work with the CDC. And you know what he found? Only 11% of male suicides had antidepressants in their system versus 41% in females. Right? Because men don't want to seek treatment. We have to shift the cultural tide so that seeking help becomes a sign of strength. Now, this is my friend Kim Ruoko. This is one of the most important things I can tell you as well. She's the spokesperson for the Tragedy Assistance Program, and her husband had untreated depression for many years. He was a Marine pilot. He went to his commanding officer who said, listen, everybody goes through this. We've all been there. Take some time. Take care of yourself. But whatever you do, don't go on treatment and don't go on medication because you cannot do that and fly. And now he's no longer alive. And she tells a story that he was supposed to come home on leave in 2 days. And something in her gut told her to get on that red eye. And when she got there, it was too late. And she said, if only I had had the Columbia questions, I would have known not to leave him alone in that hotel room that night. At least she would have had a better chance. So at that same meeting at the White House, we spoke about people die at home. You're going to hear me talk about the need to find people where they work, live, and thrive. So you see, every one of your patients can actually have this little card. You see how it says Columbia Orthopedics? Ask your spouse, care for your spouse. We make it for everybody. It's a vital part of what we need to do to save lives for each other and for the people that you care for. Until a few years ago, you couldn't have depression and be a pilot and keep your license. You could have anything else and get treated and get evaluated. Now there are 5 medicines, so they're making progress, but we still have a long way to go. So what happens when we actually do something about it? It used to be in the military that if you needed a mental health visit, you'd have to go to an outpost, and nobody would want to go there because that walk was stigmatizing. So they built something called the Behavioral Health Data Portal, which is a kiosk that normalized it, brought it within general medicine. And you know what? The Army reduced suicide. They also saved $30 to $40 million by reducing unnecessary overnights by 41%. Again, not about the money, actually about all the negative sequelae. You guys know that ironically, the time of greatest risk is post-hospitalization in the military or in the general community. This avoids all that struggle to reintegrate, the false hope, etc. You know, I'll never forget the story, right? These individual stories. We have the big data. Fort Polk, Louisiana, the provider looked towards the end of the visit at the Columbia that was printed out. Oh, you have a rope in your car and you want to kill yourself. She immediately redirected her treatment plan. It also tells people what works and what doesn't. You can use it to track change and benefit and worsening in your patients or in your systems. So what is it? You know, the Columbia are a few simple questions to identify who needs help and connect them to care. And every one of them can have the next steps. This is primary care. Next steps connect to what is appropriate for primary care. Have you wished you were dead, or have you actually had any thoughts of killing yourself? Only if that one is yes do you ask 3, 4, and 5. Have you thought about how you might do this? Have you had these thoughts and had some intention of acting on them? Or have you started to worked out the details of how to kill yourself? You cannot have methods, intent, or plan an intent if you don't have a thought of killing yourself. So 3, 4, and 5 are subcategories. And then on the screener, the behavior question: have you done anything, started to do anything, or prepared to do anything to end your life, with all the examples? You know, so this really summarizes it. You know, it's actually over, I think, 160 languages now. It is the, you know, reduce suicide, reduce workload, reduce liability. But why? Why has it been chosen? One of the things that it does is it's the first time we have evidence-based thresholds for imminent risk, and it's the first time we get at the full range of behavior. In the past, you would be lucky if you got asked about a suicide attempt, and then you missed the person who bought the gun or wrote the suicide note or collected the pills, things we absolutely cannot afford to miss. And you know what our data shows us? Of the 1%, 87% were those things that we were never asking about before, and each one of them is equally predictive. Now, I'm about to talk about this public health approach, finding people where they work, live, and thrive. These are great examples. Everybody can be part of the solution. This is Zero Suicide in Connecticut. A front desk staff member noticed somebody didn't look good, knew it was okay to ask. He disclosed the suicide note, and they were brought to the hospital. Every shooter pretty much wrote a note. You know, you just never know what's going to help. Again, evidence-based threshold. We now know who to worry about. And guess what? When that policeman has to take everybody because he doesn't know who to worry about, that actually shuts that person down from treatment when they need it. When, you know, that ED nurse has to put everybody in that ED hold room, it shuts that person down from treatment should they need it in the future. You know, now Joint Commission says why they want the Columbia everywhere, but my first call with them, I'm like, oh my gosh, this is going to be so helpful in reducing those unnecessary ED holds. So wherever you look, it's redirecting resources. One-to-ones go down. And I always say that it's about getting care to the right people. One system said, you know, we had 20 one-to-ones, but we didn't have 20 people to watch them. So before this, it was like playing Russian roulette. And guess what? There was a very exciting study that came out from Sweden in their ERs that predicted death by suicide using imminent risk timeframes. Has never happened in the field. Really, really added to unprecedented science. It's a very important study that really, you know, helps you know that we're doing the right thing.
We received a 911 call from a woman named Joan who said she was upset and afraid she might kill herself. So I was dispatched to her location. I've been in situations like this before where it was really hard to tell if someone was actually in danger of suicide or not. Fortunately, I was recently introduced to C-SSRS, and I could use a few quick questions to help me decide what level of care she needed. Hi, are you Joan?
Uh-huh.
I'm glad you called us. We're gonna get you some help, okay?
Okay.
I'm gonna ask you a few questions about your thoughts and behaviors over the past few weeks to help us better understand how to help you. Is that okay?
Okay. Am I gonna have to go to the hospital?
Let's just get all the information about what's going on first, and then we can talk about that. All right?
Okay.
Good. Have you wished you were dead or wished you could go to sleep and not wake up?
Yeah. I wish I was dead right now.
Have you actually had any thoughts about killing yourself?
No, I would never do that.
Okay. Have you ever done anything, started to do anything, or prepared to do anything to end your life?
I mean, once when I was a teenager, I wrote a note to my friend saying I wanted to die, but nothing recently.
Okay, thanks.
You know, and I always say that that policeman doesn't want to hospitalize somebody unnecessarily, and that young woman needs a referral, but she does not need to be taken to that ED hold room. And what New York State said when it went to initially to every behavioral health contact, they said what's really nice is that it's proscriptive enough for the non-professional. That policeman has a formula, right? It's color coded. There weren't any high risk answers, but it's flexible enough just to inform your clinical judgment as a provider.
We received.
So, you know, the first time before it became policy at the VA, the Detroit VA system, they said, you know, we love this scale. We can't wait to do it. But don't you ever think we're going to get 1%? We're a VA. So they did a study with the more high risk vets, the ones that were going to see their psychiatrist, and only 5 out of 3,000 needed more acute care. So what it does to redirect your care is pretty amazing. So I'm not going to get into details, but this is really wonderful. This is Centerstone. There are all these very well delineated high risk alerting policies. So when you get the 1% answer, you go into red in the crisis pathway, and then there's another formula to take you off. Really, really, this is New York State's EHR. It's not just the Columbia. When you get those 1% high risk answers, the big red suicide alert arrows go off, and that travels with the person. So if you're off the grid, and for 3 years, you show up, some clinician will have that. I cannot overstate for you guys the importance of that, that high risk tracking information. So Centerstone said, with so many patients, it's like mining for gold, and Columbia is the sifter. And when you do universal screening, same thing, only 1%. It's not opening the floodgates. It's doing the exact same thing. Why weren't people asking before? They didn't know if it was going to put a thought in their head. No, people want to be asked. It actually relieves distress. Okay. They also were worried about liability. We don't have a perfect formula. We may never have a perfect formula. How could I ask? So people have said for a long time, if you ask these questions, it protects you because we have a responsibility to ask, and because it has more data than anything, 120 studies. But the Navy providers also said, you know what, it also helps with that internal liability. At least you knew you did everything you could, right? So it is kind of minimum standard of care, provides legal protection, but not only in healthcare. This is MIT when they had a suicide, like every university, the Supreme Court mentioned it as the reasonable standard. So that frees up the teacher, the resident advisor, the parent to be able to ask and not worry about that. This is the state of Connecticut using it as, you know, police as a liability protection so people can actually do their job. So I've been telling you, I have to tell you a story. You know, clearly you don't need to be a mental health professional to administer it, and everybody can be part of the solution. I went to give a talk in Connecticut, and this huge system said, you know, we gave it to the janitors. And this clinician from the VA said exactly right. I'll never forget that case where the only person that vet spoke to was the janitor. And there's states where it's policy for the janitor and the receptionist. We really can make every single human being part of the solution within the walls of the hospital, as well as outside the walls of the hospital. So we know that we have to have a public health approach. This was the urgent memo from my co-director, Dr. Franklin, right? We must put the Columbia in everybody's hands because most people don't get to the doctor. You saw what that did with the Marines in that CNN clip. It not only reduced suicide, it reduced domestic violence, binge drinking. Then the Air Force put it in every airman, every spouse, dentist, etc. They were the only service to lower suicide, every clergy, right? We've seen with big data what it can mean. And this is what a lot of most states and communities look like and can look like. And Tennessee, where it's the crisis assessment tool, they said it's so important that school is going to be doing the same thing as the EMT, as the nurse or the doctor that quickens care to the people who need it. And state after state after state has said, since doing the Columbia, we've lowered suicide. Why? Because it's connecting the right people to the care they need. And this is what every system can look like. All linking of systems, little kids, softball, no matter what. And it has become the language. This is the CDC document. You see the C-SSRS and the definitions, but also the unacceptable terms: completed suicide, successful suicide. We're trying to take the pejorative or positive connotation away from this. And now this, like I said, helps you or NIMH or CDC know what works and what doesn't. And I think I do have 1 minute. I'm going to just
I couldn't be more pleased to tell you that the services meet on a quarterly basis. Their suicide prevention program managers we've had 2 of those meetings so far. They're 2-day meetings. They share a number of best practices. I could give you examples, and you heard in some of their testimony where some of them are implementing similar tools like the Columbia Suicide Severity Scale or the VA safety planning. They learn that from each other, and those are exciting opportunities. And I absolutely see that as the future of the office. We've also
So they learn that from each other, and you guys can learn it from each other, chaplain to chaplain, doctor to doctor. Joint Commission says, now when everybody's using this, the same language helps us focus on folks who are at highest risk. This is so critical, right? Within a community and the links to the community, we need that common language. And like he said, that can literally be like medicine. We know that a common language can build cohesion. It builds connectedness. The CDC tells us that connectedness is one of the most important things we can do to save lives. And now during COVID, if you're lucky, you get telehealth once a week, all the more important to check in on your friends, your coworkers, your neighbors. And lest you doubt the importance of connecting, a study of its opposite, loneliness, showed us that that's equivalent to smoking 15 cigarettes a day, more lethal than heart disease or obesity. And the Columbia is more than just a method to identify someone at risk. It's a framework for normalizing and reducing stigma. And by the way, when you ask, it actually helps you. We know with other mass traumas that the altruistic element, the helping others, actually helps us all heal. And I want to say that one of the things, it's just as important to have feasible and innovative delivery as it is to have the right questions. So Amazon says they may put the Columbia on the side of a box. You can have posters. It can be around the water cooler. It can be around a lanyard. We hope you'll see it on a side of a bus. The point is we have to get it in everybody's hands. And that's critical. That's a fun problem to have, but it's something you want to think about in your settings and your community. So I did talk about the silence, and, literally at one point, learning to wash hands began saving lives. And now this can be similar to that. And by being there for each other, we can build resilience that will span generations. And, Israel, in the people in charge of prevention said, it's not only saving millions of lives, it's literally changing the way we live our lives, breaking down barriers that have been built up over thousands of years. So the 3rd generation Holocaust survivor who never had a voice does. Parkland said, now as a community, we don't have to sit back and feel powerless. We can be part of the solution. I also want to just tell you one anecdote before I take questions. I'll never forget, I got an email from the head of the hospital system in France. And she said, I can finally be romantic with my husband. Very French, right? But what she meant, and this is important for you, she could finally worry less about who to worry about. And that's one of the important things I hope this will help you do. So now I am open for any questions you might have.
Fantastic. Kelly, I think you inserted a charge into this conference today with your energy. And I think 15,000 people are sort of feeling that buzzing right now. Like, where do I go? What do I do? Where do I get this? How do I start? So could you just give us the practical sort of next step? Where do you get the form? How do you use it? How do you implement it personally and in your agency?
Fantastic, right? So this is my email. This is our website, okay? And the website is a vast array of resources. You can download the cards, download the questions. You can come to us. We send and we personalize them, right? We work with systems. We have calls. We think of ourselves as a 24/7 guidance, right? We work with policies, big policies with states, with hospitals, or we help practitioners. So we are here to guide you. Go on the website, you can get it immediately, okay? But how is, I wanted to say this. People often ask, how often, right? Every single time you can. God forbid the time you didn't ask is the time you needed to ask. Dr. Stanley, who's the author of Safety Planning, one of the great interventionists, and also an author in the Columbia, says if you have a treatment visit and time to do one thing and one thing only, it's do that. And by the way, so in every shift, nurses ask it. If you have an outpatient visit, they can fill it out in the waiting room. You don't have to even take any time, but you can. It takes like 10 seconds, but you have to think of this like blood pressure. Anyway, we're here. This has been hundreds of millions of times across the globe. It's very, very scalable, and you'll see how easy it is to start. And we're excited. We're excited to help you.
Mm-hmm. So many people here already use it in their agencies. I think there's always questions of when you insert another form and questionnaire, it's more time, it's more this, how do we do this? But I'll tell you, a lot of the people in the Q&A are saying, we do this and it's pretty easy. So that's good news. I don't always hear that on these presentations. So Good for you, making it very simple and usable.
Absolutely. And not only, I'm so glad they said it's easy. What we hear again and again, it's not only easy, it's making it so they don't have to spend the time that they need to care for the people who really need help, right? Right. So it's very rewarding to be able to focus on that 1%. That redirection of workload makes your job much more effective.
I agree. I don't know. I'm a therapist myself, and it was always really difficult because you had this sort of liability mentality. And I loved what you said about the university, showing that this is considered reasonable effort, that if you do this, you can at least, and not that it's about us as the clinicians, it's about the person in need, but you really can decide who needs the extra level of care and who needs a referral. And you can really fall back on that.
Exactly. And that's the key. Like I said, connecting the right people to the care that they need. And one state official said, you don't get into trouble for a bad outcome. You get into trouble for not doing something, right?
Yeah. It's a good way to put it. How about age groups? How young? I think that's a big question.
Across the entire age span. So it started in kids and youth, and there's actually something called the very young child version, which is for like 4 and 5-year-olds, but across the age span.
Mm-hmm. Great. Is there like a business card version that you can just carry around?
Yes. So we make cards all the time. So people like in the Army, they put it in their pocket. You saw that lanyard, right? So every time I go give a talk, we give these wonderful bags and clipboards that we give to everybody. You'll see hospitals, everybody walking around with a yellow clipboard, but also the cards. And the cards can be as small as you want them. People have made wallet-sized cards. So you can put it in your small pocket. It's very, very flexible, but that's a standard way that it's actually done.
Okay. So next steps after the protocol, does the Columbia protocol also include a kind of standard safety plan that you could fill out?
So what a great question. I'm so glad you asked it. So remember I said proscriptive enough, but flexible enough to just inform your clinical judgment. What does getting high risk mean? All it means is you need a further evaluation and you want to keep them safe. That's all it means. So if you, as a clinician, get somebody and you're trying to decide whether to hospitalize, and they actually had a high risk answer 29 days ago, but they got back together with their girlfriend and everything's fine, you will decide maybe not to hospital. They might not have anything on the Columbia, and you decide they need a certain type of care, right? All high risk means is you need a further evaluation, and then you can use your judgment. And there are lots of examples. There's a C-SSRS safety, which you'll see. There's a formula, right? You get these answers of 4, 5, or 6 in a certain time frame. It's high risk, and that is connected to certain interventions, safety planning, et cetera. So there are lots of examples of what a system can do depending on what the answer is.
Right. Good.
But formulaically, it just means getting a high risk. And we have on the website, I believe, and we can also send it to people, many, many examples of the care delivery mechanism.
Good. Correction, there's a lot of people here apparently from correctional facilities, which I'm glad they got the time off. That's great. But inmates, particularly short-term inmates, are going to use this as leverage. So that's the idea.
Such a great question. So when I showed you very quickly that model of the states, right, with all the linking of systems. So Department of Corrections across most states, or juvenile justice, were the first ones that we went to, and we would talk about literally putting it in everybody's hands. And I'll never forget going to Sing Sing and sitting and listening to these inmates and really understanding how badly it was needed. Actually, when people are suffering, they actually want help. And these questions typically are not so easy to play, but what they do, so California is the biggest system. They said that, when this was like 10 years ago, they spent $24 million in one-to-ones in 1 year. And they said, what this will do for us, right? Cut it in half, actually help us deliver constitutionally mandated care, right? So we've seen tremendous usefulness in this, and really guards. I mean, anybody can do it. It can be self-report. So we kind of see the opposite, and that's the good news.
Mm-hmm. You mentioned you go to hospitals and whatnot. How would people, obviously it's very easy to implement, but how would an agency bring a training in?
They email us. I'm laughing because I always give my cell phone out. Maybe I won't today with 70,000 people, but maybe I will. But so you email us, right? Where our center helps work with big systems and little systems, and we will, and we also sometimes we talk to leadership to kind of figure out, we take policies and we say, you know what, you want to optimize here, there. And so systems all over get us to help them. And very often a system or a hospital becomes the center stone and the centerpiece or the lead for the whole community, which is really beautiful. And they invite police and education and community members, and you become the facilitator, which is awesome.
Yeah, I to get on my soapbox a little bit, this is just a great tool, not just for clinics and agencies, but also for the schools in the area, the universities in your area. You, as maybe a private practice therapist in your community, might be having these agencies reach out to you, or agencies and schools and universities wanting to know what to do. This is a great thing to bring and introduce into their systems.
Can I just add to that too? Bring it to your suicide prevention coalitions. What we've found now is the thing that works so effectively is when now top down is meeting bottom up, because these state policies that use the Columbia, it takes a long time. So community engagement, like Beto O'Rourke flew me out to El Paso, and literally sanitation, librarian. I mean, every single person and every single member of the community can be part of this.
Probably one of the more inspiring parts of your talk today was watching actually that training video with the officer asking the woman standing at the fence those questions. training videos, we all know, can be pretty lame sometimes, but that having worked in community mental health myself and seeing unnecessary hospitalizations, seeing unnecessary restraints, seeing officers, very, very well-intentioned officers, not knowing what to do. That was a really great thing to see him be able to sort of triage what kind of care she needed. So this has been fantastic. Kelly, any closing thoughts before we go?
Well, I was just going to say, when you said about the policeman, I showed you this card in the beginning. Ask your community member, ask your fellow firefighter. So the firefighter can actually do what you just said, and actually they can help save each other's lives. So as part of the governor's challenge, when every firefighter in Houston, Texas got this card, so many came forward. You know, I can't tell you, you'll see the little sheriff's office, you know, for years has been using it. But again, if we can actually get this in everybody's hands, that's your challenge for today. We need partners.
Okay, everyone, you heard her. This is the challenge. So hopefully everybody's crashing the Columbia site right now. If it's down at the moment, just visit back, because so many people are visiting. Justin Baker is coming up next. He's the head of Strive, which works with veterans. I think it's just going to be incredible. So please stick around for Justin in about 15 minutes. Got a full day ahead of us. Hopefully you're finding some space. I know these online conferences, it can feel so hard to just stay attentive. So do what you need to do to work with yourself to really be here and get as much as you can out of it. Kelly, thank you so much for joining us. And I can vouch that Kelly has a whole team. If you email, you're going to hear back at some point very quickly. So she does have a team and they want to help you. Thank you again, Kelly, for being here, and everyone, we'll see you in about 15 minutes. Bye-bye. And I think Maddie's having a